Surgery becomes a challenge. Here, when to do, what to do, whether to do becomes more of a challenge when it comes to trauma management, traumatic cataract management in children. So when it's trauma, first the aim is to restore globe integrity. These are the problems we face. Visual axis is the first thing to be thought about, and then optical correction with amblyopia management. So blunt injury, penetrating injury in children or in any situation gives you a array of cataracts situations which we have to probably decide when to do, what to do, etc. So penetrating injury with various scars at various positions, various time. So we'll see different scenarios of traumatic cataract and its management, when, how, and along with what. So these are the different scenarios, like 5-year-old with iron injury 2 days prior, 4-year-old 1 week post iron rod injury, 11-year-old with 1 week post iron nail injury, bicycle injury 3 months prior. This is post primary repair. So various situations we come across when we sit in OPD with a child having had a trauma. So what are the questions that we address? When do we have to manage the cataract? Like, is it during the primary repair itself? Is it, or if not, then when do you manage the trauma and when do you manage the cataract? Is it at the same stage or at a different stage? Then IOL implantation, do we plan it during the surgery, during removing the cataract, or as a secondary procedure? And if IOL implanting, where do you implant it? Is it in the bag, in the sulcus, or where? And additional procedures, if there is concurrent injury to the iris, glaucoma, vitreous, etc. So do we manage all that at the same time or as a different setting? So these are the questions probably we'll have to address. So cataract management at the time of primary repair in any trauma, in children especially, do we really do it? If yes, when, why, and how? Do we ever consider IOL implantation at the time of primary repair? Primary repair, by which I mean when the globe is open. So do we do it? So this is a situation where it's a 5-year-old iron nail injury. Every time I stress the age also, it's very important. 2 days prior, you have this injury. And this is a second situation, 11-year-old with a stick injury, 1 week prior with a small corneal self-sealed wound in the inferior portion. So the first situation, we manage the corneal tear first, and the cataract surgery probably as a secondary procedure, because the corneal tear doesn't look a very good thing. You may have chance of introducing infection inside. And here the corneal tear may not even require an primary repair, so you can just go, and obviously the lens matter is in AC, so it's all fluffy cortex. You need to remove the cataract now at the first sitting. So then what does the literature tell us? Literature tells us that cataract surgery during primary repair, if at all we do, when there is a large breach in the anterior capsule and most of the cortical matter is in the AC, there is no other option. Why? It reduces postoperative anesthetic risks because multiple surgeries may be avoided. Early visual rehabilitation because visual axis gets cleared then and there, and amblyopia management, etc. is possible. And you have a good chance at that time to see the fundus and the posterior segment involvement. Why do not we do? Because you have a quieter eye when we manage it as a secondary setting. You have a stable wound, and of course, if there is a possibility of IOL implantation, you can plan it when you plan cataract management as a secondary procedure. So if at all we do IOL implantation during primary repair, very, very few reports are there in children. It is best avoided. You have a chance of introducing infection. You don't know so many factors you're managing at the same time. So increased risk of inflammation, calculation difficulty, all these are there. So then if cataract is not managed, then when do we do it? So this becomes the second question. So what is the ideal time between trauma and cataract management in children? So this depends on so many factors, like what are the factors? See this particular patient, it's 2 days post-trauma, post-primary repair actually, 1 week prior to the injury. So this, you see the cortex kind of disturbed, you see the visual axis is not clear. This is a 2-year-old child. So when do we do surgery for this child? The next day itself, next week, next month? So how do you decide? What are the factors? Of course, the age group. The younger the child, clearing the visual axis becomes the priority. IOP, like you leave a cortex loose and an inflamed eye, IOP doesn't settle, you have spikes. And inflammation, of course. So these are the things which tell us when to do the cataract surgery. So this was that child which we showed. So this child, because the child was 2 years old and corneal wound which is very irregular and fresh sutures, we decided to clear the visual axis as the first priority by doing a bimanual lens aspiration. So you clear all the synechia. Within 2-3 days also synechia can form. You clear all the synechia. If there is corneal wound, capsule, anything tag is attached, you try to clear the cornea from the rest of the segment. And the idea here is to remove as much as clear the eye of cortex very well, and we had to do a vitrectomy also, anterior posterior capsulotomy and vitrectomy, because the child was very young. So another few scenarios, like 8-year-old boy with injury 8 months back with the handlebar. Here this is a very quiet eye, stable peripheral wound. So when do you do the surgery? You can do it anytime actually. 8-year-old boy, visually significant. Amblyopia is not a risk, but you can plan it as an elective procedure. So the third question is, you do the cataract surgery, but what about the IOL? Like which IOL to put, when to put, and how do you calculate the power, etc. So in the bag, acrylic hydrophobic single piece any day is the first option, best option. If not, then in sulcus, 2-piece or 3-piece IOL is the second option. And if the rexus is very large, bigger optic IOL, even a PMMA IOL can be used in trauma. So corneal injury determines actually if it is peripheral or central, you decide when to implant the IOL, at the primary setting or once the cornea heals and you remove the suture, once you get the IOL calculation. So this is a primary, it's a blunt injury, you have more chance of having a little controlled intact capsule, and IOL calculation may not be an issue because corneal injury is not there. When there is a corneal injury, if it is peripheral, again IOL calculation may not be an issue. So the capsule then determines the position of the IOL, the presence of the intact bag. So you can place it in the bag or in the sulcus at the time of cataract surgery. So then there may be various different ways of others doing it. Yeah. So the next few questions were like IOL implantation. Love covered when there is a unstable lens, like when there is subluxation. Trauma has a stable subluxation. In trauma, subluxation does not progress. So the Sionis ring and all that comes into play. And then aphakia management. If you're not able to put IOL anywhere at that setting, there is always a chance of SF IOL, etc. Concurrent injury like iridodialysis, if it is large, all that has to be sometimes managed along with the management of the traumatic cataract.
Thank you, Dr. Kavita.